Welcome to the Doctors Making a Difference podcast, where we help physicians to be empowered with the tools they need to be successful in medicine, in finance, and in life. Join us as we highlight doctors and other professionals around the world who are making a difference. Think about how much the United States healthcare system has changed in the last 50 years. I've only been a physician for about 15 years, and I've observed a lot of changes. The number of administrators versus the number of clinicians, the amount of money that we spend relative to our gross domestic product, and the system that we all kind of work in and feel like it's broken. And yet it seems like there's no easy answers. It seems like every answer seems to want to spend more and more money, and our insurance companies seem to make more money, and they never seem to suffer any loss. But our patients and our hospital workers often find themselves overloaded because of increased burden. And we live in kind of crazy times. I am excited today to interview Dr. Joseph Jarvis. I think you'll really enjoy his passion, and I'm really excited to present this podcast to you. I'm pleased to welcome Dr. Joseph Jarvis today. Dr. Jarvis comes with a lengthy list of experiences and publications and has done so much for the world of medicine. Dr. Jarvis, would you mind introducing yourself to our audience briefly so they know who you are?
Yes, thank you. And thanks for having me. My name is Joseph Jarvis. I practice public health medicine, mostly as a consulting physician in Salt Lake City, Utah, with clients from across the entire country, from Guam to New York City, I like to say. I'm now semi-retired. I've trained at the University of Utah, originally in family medicine. And I actually served in Salt Lake City on the northwest side of town in a community health center, federally qualified, for several years before beginning my public health career, which has included stints of duty in the federal government at the Occupational Safety and Health Administration, and then in the health departments of the states of Nevada and Colorado. When we moved back to Salt Lake City about 25 years ago, we did so for my wife's career, and I left behind my institutional affiliation at the Colorado Department of Public Health and Environment and began just serving clients, mostly with environmental health problems, cancer clusters, indoor air quality issues, workers' compensation cases. And I've been doing that pretty steadily since then, although, as I mentioned, I'm reducing the load there because I'm more and more interested in health system reform, and I'm spending more and more of my professional time in an unpaid volunteer advocacy state, trying to help mostly here in Utah, although I've got friends across the country. I've published books about this, and recently, 2023, released a movie that I produced about the problems in the American health system and a little bit about what we can do about it.
Yeah, well, you and I are both graduates of the University of Utah School of Medicine, so go Ute. That's a great thing we share. I think this is really interesting because when I talk to most physicians, most people they're one thing. Like they say, I have been a surgeon for my career, or I've been a primary care doctor. You've kind of done all these things. You've been a primary care doctor. You work in public health. You worked in a university system. You've published and you've directed a film. You've done lots of different things. And so that journey alone is pretty interesting. You know, you've been able to stay engaged in medicine in a variety of ways for a lot of years. I'm just curious, as we're going to get into kind of the content of some of the stuff that you have taught, but how did you find the motivation and the way to stay engaged for a lengthy career and such a varied career?
The underlying motivation for me in medicine has always been that I believe it's my calling. As a young man, even as a child, I was interested in what physicians were doing. I observed it as they treated me and as they treated members of my family. And I became interested in what that was all about. So I pursued it as an undergraduate. I did not take a classical pre-med undergraduate degree. I was an English major, very interested in literature and fiction, especially, and writing, but maintained the coursework that's needed to sit for the MCAT and then eventually get into medical school. And it was kind of a toss-up. I had an opportunity to go to law school instead. But when a position was offered me at the University of Utah School of Medicine, I felt like that was the right thing for me to do. And it's been that way ever since. And the more I've gotten into medicine and the more I felt like I could contribute to the people around me, first as a primary care doctor, looking at everything, delivering babies, caring for the babies afterwards. I was the only doctor in Salt Lake County doing home visits for the elderly for a while. Those were very, very enriching experiences for me. I believed I was doing God's work and not just earning a living. And then found an interest in preventive medicine, public health, that I felt like I could then have an impact in a broader community. So I began pursuing that career, which eventually morphed into a career in occupational and environmental medicine, because that's a subset of public health. And I got invited onto the faculty of Tertiary Care Center in Denver, the National Jewish Center, which is a respiratory diseases hospital. And I was doing occupational lung disease. My patients came from all over the country with occupational asthma and black lung, and just kind of led automatically into investigating outbreaks of occupational lung disease. And eventually that became my career for some 20 years, serving as a consultant. Every setting, it felt like I was doing God's work, like I was where I needed to be to help people. And that was a blessing to me. Now, as I realize that there are so many people in our country who can't get the care they need, I've become persuaded that it is, again, it's a calling, that I need to try to help people see what's wrong, that we can't continue like this, that our nation will not economically survive if we continue to have a growing percent of the gross domestic product devoted to healthcare. We have to actually change how we're doing healthcare business. And that feels like the right thing for me to be doing at this not kind of late stage in my life. I'm now not doing it so much for myself as I am for the succeeding generations. It's not just the needs of patients who aren't getting the care that they need. It's the overall need of our society to come back together, to be healed as a society, which I think the divisions have occurred because we failed in healthcare.
And, one of the purposes of this podcast is try to leave medicine better than we found it. And mostly the audience are physicians. How do we have tools and resources that we need so that we can be effective in our care? And I want to just highlight the stuff you've said. When you speak about public health care reform and about all these different things, you speak about it authoritatively. You've worked in primary care, you've worked in a specialty center, you've worked across the spectrum. And so another question that kind of may lead into some of the observations you've had, you've also watched this over a prolonged career. And before we hit record, we talked a little bit about how there was kind of a shift where we sort of turned from caring for one another as society, as individuals, as communities, as congregations, and maybe turned a little bit more toward big systems that are profit driven. And I wanted to kind of pick your brain. What have you observed over your career? What are the changes you've seen, both good and bad, that have contributed to the problems that we're into today?
The most stark moment in my career where I saw something really sinister developing was when I shifted from my training home state of Utah, where I now live. Now, this is many years ago. At the time, primarily a nonprofit hospital system, or several systems of nonprofit hospitals, to Nevada, where I became the state health official or state health officer. And I had a duty to regulate hospitals, nursing homes, and HMOs. And one of the stark things that I immediately noticed was it was far more expensive in Nevada to get care. We were expecting our fourth child when we arrived in Nevada. And so we'd already had 3 babies, all 3 of them born in Utah. And the cost for that pregnancy and the delivery was multiples above what it had been in Utah. And that's despite the fact that when we first arrived and I was getting acquainted with the medical community, because I was, after all, the lead public health officer in the state and needed to know the physicians. One evening I was with the pediatric community in Reno, and one of the doctors came up to me and said, "I noticed your wife's expecting. I want to advise you that if there's any problems with that pregnancy, don't have that delivery here in Reno. We don't have good neonatal care here in Reno. Go back to Salt Lake and have that delivery, because the care we have in intensive care for newborns is terrible."
Really?
That struck me. What? That's how these people feel about the care in their community? So I began looking into it, and I realized it was far more expensive in Reno, but the mortality rates were far higher. than they were in Salt Lake or even Las Vegas. And that sort of experience happened over and over again. I was given the duty by the legislature to regulate trauma care, and I was trying to organize a trauma system. Here we were in the most expensive state in the country for hospital care, compared to Utah, which was the least expensive. And there was no trauma system. And Utah already had long since had a trauma system. There was no organized open heart surgery. Like Utah had already long since organized that. Neonatal care was not good. And Utah had a lot better neonatal. And yet I kept thinking to myself, why is care so expensive in the state where the actual advances, the technologies, the care, the perfections of the care are so much worse than they are elsewhere? And it began to dawn on me that it has something to do with Nevada being an almost all for-profit hospital state and Utah being an almost all nonprofit hospital state. I went to the lead hospital in Las Vegas, the one where President Reagan's, who was our president back then, his advance team would always pick that hospital to take him to if there was trauma, if there was some kind of issue.
Right.
And I've sent out an RFP or request for proposals for hospitals to apply to be the lead trauma center across the state. That hospital didn't apply. And other hospitals that did apply could not, they failed the test. So we couldn't designate a level 1 trauma center. The one that actually had the capability to do it refused to apply. And I ran into that CEO and I said, what the heck? Why didn't you apply? You would have won that. You could be our lead trauma center. We could be building our trauma system around you. And he said, it's really simple. You're the regulator of hospitals in the state of Nevada. You have regulated us and granted us a license. And I can't remember the exact number, but let's say it was for 450 beds. He said, we don't routinely staff up to 450 beds. We staff up to like 350 beds. If a patient comes into the emergency room, my staff is trained to figure out whether they can pay for that hospital bed. And if they can, call in a nurse, staff up, and we admit them. But if they can't pay for it, then we tell that family that we're full and we divert them to some other hospital. He said, your rules for the level 1 trauma center that you pass through the Board of Health require that the care has to be allowed at the level 1 trauma center for trauma patients, regardless of ability to pay. He said, I'm not in business to take care of Nevada's trauma patients. I'm in business to make money. And I can't accept that regulation. And that was the moment when I realized we have a problem.
You're right.
We have a real problem in the United States healthcare system when the profit is what they are all about and not actually the patient care. So we need to really advise ourselves, really carefully understand you can either have very profitable hospitals, optimally profitable hospitals, or you can have optimal patient care, but you cannot have both. They are mutually exclusive. That's what I learned early on. That was a driving moment for me in changing how I approached what it was that we needed to be doing.
I mean, that's a crazy story. Most of the podcast audience are doctors. Think about why you became a physician. And when you were writing your statement of why you wanted to do that and why you dedicated so much time, it had nothing to do with making sure your hospital was ridiculously profitable. Everything had to do with, how do I help my fellow individuals? How do I help people get through their health problems? And how do I make sure I make a big difference for the people and my families and all these different people? It had nothing to do with profitability, but I think you're right. And it seems like what you observed in that hospital system in Nevada has become more the rule rather than the exception. As I talk to different people that work in different hospital systems, well, we'll do that as long as it makes us money. But if it doesn't make us money, then we don't have an interest in it. And we do need to make sure that, hospitals can pay for the services they offer. But hospitals, I don't think were ever designed to be giant profit centers or things that would be really interesting to outside investors. But that is what we encounter a lot in 2026.
Yes, Nevada just happened to be on the leading edge of what became the norm all throughout the nation. Utah's hospitals now are either overtly for profit or they are allegedly nonprofit, but they act like any other shark in the Shark Tank. So they're actually ostensibly nonprofit, but not really. And that sort of behavior creates a system where a program is judged individually on whether it is making money and not on whether it is meeting a community health need and saving patient lives. Staffing levels for nurses, for instance, that's viewed through the lens of, can we still have a good bottom line, a quarterly profit margin that's better next quarter than it was this quarter if we staff at this level? And usually the answer, or often the answer, is no. So they'd staff down, they dumb down positions. There are fewer and fewer RNs, more and more aides. One time when my wife was in a hospital recovering from some serious surgery, she was having problems that looked like she might be going into heart failure. So the consulting cardiologist wrote an order for I's and O's. And I watched as the person came in who was supposed to actually do the work of measuring the fluid levels, et cetera. And I looked at the chart after she'd finished and walked out of the room. This was somebody who couldn't add and subtract, who was doing I's and O's on my wife who was maybe having heart failure. That is the kind of dumbing down that was never true when I was in training. That's not how people were in hospital staff levels. This is one of Salt Lake major hospitals.
Man, it's the same group of people. We're all descendants of the previous generation, and people approached some of these things a little bit different. Why do you think that was allowed to happen? Do you think it was just pure selfishness, or was it a regulatory change that occurred? With your perspective of multiple decades of doing this, why do you think that this was allowed to happen in the U.S. healthcare system?
For one major reason, we in the United States have big believers in market systems. We believe markets are the answer for every problem. Now that ends up not being true, and it's especially not true in something like healthcare. Adam Smith described markets in 1776, the same year that the Declaration of Independence was written. It's a remarkable document, a remarkable set of observations. And in general, I'm a market person. I come from a fairly conservative background, and I'm a believer in allowing people to be buyers in the sense that is marketing. But there are a number of these precepts about what markets or how market systems work written by Adam Smith that actually just don't apply to healthcare. And we ignore those misfits and keep acting as if all we need to do is just figure out how to get that square peg of healthcare into the round hole of markets. Patients are not buyers, not in the sense that Adam Smith meant them to be. Buyers must beware, he said. Caveat emptor. You're supposed to be able to know, you're the only person who knows what you want in the marketplace and how much you're willing to spend on it, or how much makes sense for you to spend on it. So you have to be aware of all those exigencies. Well, I'm sorry, patients aren't aware. I used to have a big argument with an anesthesiologist. I got invited onto all kinds of public discussions about health system reform over the last 20 some odd years in Utah. And I would be talking about market systems don't work. And he was a big market proponent. He was somebody I'd known since we were young men, both serving an LDS mission together in Austria. So we were friends, but had this definite difference of opinion until one time, and we hadn't seen each other for several months. And we show up for a big debate, and I threw out the red meat so we could have the fight that everybody expected. And he didn't pick up the challenge. And afterward, I said, what happened? Why didn't you argue with me? I mean, this was the entertainment everybody came for. And he said, I no longer believe what I used to say. I believe what you say. He said, I was shaving about 3 or 4 months ago in my bathroom one morning, and I had a heart attack and fell to the floor. And I was completely unable to help myself. So I'm an anesthesiologist. I know what drugs need to be run in. I know what needs to happen, but I could not do anything. I could just hope and pray that somebody would come who knew what they were doing and get me where I needed to be. He says, fortunately, that's what happened. But I realized what you've been saying all along, which is patients are not buyers, not in a market sense. He says, that's exactly right. Patients don't know, and they can't know, and they can't do, and they can't make decisions. The second principle of markets is that sellers have only one interest in a market, and that's to make as much money as possible. We don't believe, in a sense, doctors are the sellers, the primary sellers of what is offered in the healthcare market. But the truth is, doctors will violate the Hippocratic Oath if they put their profit before everything else. So we actually have expectations, professional, ethical expectations of doctors and nurses that violate market principles. The third thing in a market is that the buyer and the seller are the only ones that care about the transaction. Well, in healthcare, that's just not true. We all care about these transactions. If it's a case of tuberculosis that is needing care, obviously we all have an interest in seeing that case gets treated, because
Right.
otherwise it's wandering around the streets of our city or town, exposing the rest of us. But if it's a trauma case, we need that case to be brought in a communal fashion, in not a competitive way, but a supportive way, a way that we all agree to, so that we're all benefiting from it. They're all brought to the same facility. The worst cases are where the same doctors and nurses practice and get good and stay good at those skills. Because even though I'm not the trauma patient today, I might be that trauma patient tomorrow, and they need to be prepared for that if I'm to get the best care. And finally, markets are places where what drives demand for the product, the service, the good, whatever, what drives demand is the price. And it's an inverse relationship. The lower the price, the greater the demand. Because in markets, demand is elastic. That's not true in healthcare. What
Right.
drives demand in healthcare is epidemiology, the frequency of various health problems. How common is trauma, for instance? That drives demand. I'll give it a good example. I'm not a diabetic, and my interest in having and acquiring insulin is not elastic. I don't care about having insulin. I don't need it. I don't care if you give it away. I won't go get it. I
Right.
won't let you give it to me at my front door. There's no elasticity in that demand, no matter what the price is. If I'm a diabetic, on the other hand, it doesn't matter how high the price is. My demand never slackens. It's not elastic. I've never heard of a patient getting an appendectomy because it was on sale.
That's
Okay.
true.
That's just flat not how it works in healthcare. And that is a great sign that markets don't apply. The problem is we keep pretending like they are applying to healthcare, and we keep acting that way, and we ruin the opportunity to actually do what we know how to do. We physicians know and nurses know how to do. We know how to take care of patients, but we let the market forces, the business interests, ruin it over and over again. That's the underlying recurring mistake that's being made in American healthcare that we got to fight against.
No, I thank you, and I appreciate your passion on it because you're right. All those things are true. Like, none of my patients come in and are, we're not running a sale on appendectomies. We're not running a sale on anything like that. And if a person needs, like, for example, insulin's the classic one. If you can't get your insulin, especially if you're a type 1 diabetic, you will do anything to get it because without it, you die. Like, it's not really something you have much of a choice in. So it is interesting that we put all these market forces. And then just in kind of a shorter time span, in the time that I've been in medicine, I've noticed the number of people that are on the administrative team. Like, I work for a neat little hospital and we do pretty well, but I've noticed just in general across most hospitals, the executive suite, the business people and all the billing department has grown and grown and grown, but the number of patients being served and the number of procedures being done in many cases has remained fixed. And yet we're still trying to extract many more salaries out of that same group of patients. And so across the board, the prices go up for procedures or for whatever it may be. And insurance companies feel like they have to slowly meet the demand. And then over time, the price just goes up. And it seems like that's the only trajectory is up, not just by inflation, but just up by multiple times what normal inflation would be.
The percent of our gross domestic product, which is diverted to support healthcare, the medical expenditures of our country, they're remarkably high. And the growth rate is consistently faster than the growth rate of the rest of the gross domestic product. So inflation in healthcare outstrips, as often as not, it's 2-to-1 inflation in the rest of the economy. So back when I started practicing, we were already had a much bigger percent of the GDP going to healthcare than any of our other sister first world countries. But it was about 10, 11% at that point in time. I'm talking about in the early 80s, for instance. Now we're approaching 20% of the GDP. In fact, going to healthcare. In fact, there was a recent statement that said that we will cross the threshold to be above 20% of GDP going into healthcare before the end of this current decade. Just for a context on why that's important, of course, you can't spend 100% of the GDP on healthcare. You can't keep outstripping the growth in healthcare costs, can't keep outstripping the growth in the rest of the economy because we can't spend every dollar on healthcare. We have to feed ourselves. We have to build roads. We have to educate our children. I mean, et cetera, et cetera. There's a lot of other things that we must do. And if we stop doing some of those other things, sooner or later, the economy will fall apart. There's only one circumstance I can think of in modern economies where that actually happened. And a first world nation economically fell apart. And that was the Soviet Union in the 1980s. Now, they didn't fall apart because of healthcare costs. They fell apart because of defense spending. The percent of their GDP going to defense spending, which was exceeded, which too skewed the economy in that direction, that percentage was 20%. We've never come anywhere near 20% of the GDP going to defense spending in the US. It's down more like 5%. But they were at 20%. Their GDP wasn't as big as ours, and they were trying to match our spending in defense spending. That's what the history of the Cold War. That's what happened. And then Afghanistan just took them over the top, their invasion into Afghanistan. What I'm trying to suggest is we are approaching a similar meltdown, economic meltdown. The Soviet Union was a first world country. You'd have to say it isn't really that anymore. It's certainly not a world power. We will do the same thing to our economy. In fact, Mike Leavitt, former governor of my state of Utah and the former secretary of Health and Human Services, I can quote him. He said, there will never be a first world nation that spends 25% of its GDP on healthcare. And the reason he said that is you can't do that. It skews the economy too much. The wheels fall off and everything goes to hell in a handbasket. We are approaching a brick wall for our economy. Everything else will fall apart and we will be a second class nation if we don't figure out how to stop this push, this increase. I mean, when I was filming Healing Us, the movie that I produced, this was in the 2022 time range, the total amount of money spent on healthcare in the US that year was $4 trillion. Now we're just a few years later and it's almost $6 trillion. That kind of growth just can't go on. We can't afford it. As wealthy as our nation is, we will fall apart if we don't do something about this.
Well, I've talked to lots of people. The math has to work no matter what you're talking about, whether you're talking about building a home or borrowing student loans. And on a government, same thing. You can't keep just printing money to oblivion because eventually, if your percentage of money spent on one thing it exceeds the ability for the market to handle it or for the government to handle it, you're right, we'll have chaos. Earlier, again, before we hit record, you mentioned that some of these problems that we are observing with just kind of endless spending in healthcare and increased corporatization or making it more of a business venture rather than caring for our fellow human beings are emblematic or symbolic of what's happening across the political spectrum, where we've gone from people debating and trying to figure out the best way forward for our society to almost like attacking one another and thinking people are the enemy if they don't agree with you. We've become more polarized in our politics. And you suggested that maybe how we're treating healthcare and the way we treat one another in a healthcare standpoint may actually be fueling some of that discord and disarray. And I'm interested to hear more of your observations on that.
Recently, it was last June, I did a driving trip around the United States. I have a Jeep. I've done this quite often over the years, taken a couple of weeks out and just gotten off the main beaten track, off the interstate highways and get into rural America and just see what it looks like and stop and have lunch somewhere. This time I was really surprised. In rural parts of this country, I only found really evidence of three main activities. There were signs everywhere I went for lawyers advertising for injury. They were going to try to sue somebody on behalf of whatever client. So there were lawyers that were active. And there were a lot of cattle. We have livestock all over the country, in every state, as far as I could tell. And there were churches, mostly evangelical Christian churches. But for instance, I couldn't find evidence of any healthcare facilities anywhere in rural America. No signs, no clinics. I'd go to the crossroads in the towns, nothing. I often couldn't find a gas station. I couldn't find something simple to eat. If I could find a gas station where I could get a little bit of gas, it didn't mean that there was a bathroom there that I could relieve myself in. I mean, I was so taken aback. It was hard to find a school in those places. What has gone on, I think, starts with how important to each local economy healthcare actually is. Employment in the United States is dependent on
health services. That's the only growing employment sector of our country right now. If you remove that from a given part of the country, you remove economic opportunity in a lot of ways. The tax base changes, the ability of consumers to actually buy goods and services changes, and never for the better. So that trend, because of our reliance on markets and profit in healthcare, that trend against rural health institutions and health, even though we built all those with Hill Burton funds back when I was a child, federal money went out and built a hospital in every county across the country. Those things by the 80s and 90s were beginning to disappear because the competitive model, the for-profit model, can't make enough money. This quarter's bottom line isn't better than last quarter's if you're trying to deliver care and service in rural America. It gradually started being retracted from there. And with it went the economies of all these rural parts of the various states. And I think there was a growing first alarm, concern, and then eventual anger about the fact that people living there who had a lifestyle they loved and wanted to protect, they could see that the coastal states, the elites, were doing very well, but they were not, and they couldn't seem to get any traction anywhere, even though half of the citizens of our country live where there's not enough people for there to be more than one hospital or clinic. There can't be any competition because you can't build a second hospital in most, U.S. counties. Right. So that is what I think. If you have a family member who dies because suddenly there's not the urgent care in where you are available, you have to go 50 miles away to get it, and they die en route, you begin to feel a little bit like, well, I'm paying my taxes too. Why don't we have the advantages that everybody else seems to have? And anger starts. I think that's the germination of the Tea Party. And the Tea Party, who were a bunch of angry people who were just basically shouting at everyone, the Tea Party has emerged into what is now the right wing of American politics. The Republican Party I grew up in doesn't exist anymore. I mean, I'm not trying to give, a free pass to the people who are on the left side of the political line. They are as beholden to and interested in the medical industrial complex as anybody is. They're making money hand over fist themselves, and they keep making promises to America. Both Clinton and Obama did, as did George W. Bush, that they're going to solve a health problem. And they never keep those promises because the market doesn't keep promises to patients. It keeps promises to shareholders. And they certainly have kept those promises. Obamacare passed, and a share of United Healthcare stock on that day grew tenfold over the next decade till the day when Biden was sworn in as the president. That's what happened with Obamacare. It was a bonanza, a giveaway, a profiteering for the health insurance industry. Why do we have so much administration? Because insurance is not care, it's administration. And they're the ones that are dominating everything. What they do on their side of the aisle has to be mimicked mirror image like on the provider side in order to fight those administrative battles. That's what they do. That's the product, if that's what you want to call it, that they're offering to us. And they're not doing it out of the goodness of their heart. They're making as much money as they possibly can. They're robbing it, and people are angry about it. Now, if we actually believe the Bible, and especially the New Testament, that talks about being caring and kind and loving and how that will eventually pay dividends, if we follow Jesus of Nazareth and try to heal everybody, then we will bless ourselves with that generosity, and that will heal this problem that is creating all this conflict in our country. People will be less angry. If they have their needs met, they are more likely to be kind themselves when they have the opportunity to do it. We have caused this problem by failing to take care of each other. We can only heal this problem if we start to take care of each other. That, I believe, is an absolute moral truth. Charity begins here at home. We've got to do it.
No, I think you're right. If we jokingly say that, the golden rule is supposed to be do unto others as you would have them do unto you. But in 2026, the goal is whoever has the gold makes the rules. And we have to be so careful to make sure that we, again, this tenet that we're trying to leave medicine better than we found it. And I think we as physicians do have to speak up, and not just, can't leave it necessarily just to our political leaders. We have to get involved in our state societies and our state government and our federal government and say, hey, this is not supposed to be a big profit center. We need to make sure that the hospitals keep the doors open and that you can pay your staff. But ultimately, there is supposed to be kind of a safety network. I work in a critical access hospital, and critical access hospitals are under stress right now because there's been big federal cutbacks and state cutbacks, and it's really quite challenging. And you could see that safety net go away pretty quickly if it all becomes a business model. It's all going to say, like, we'll drive to the bigger city and have your procedure or go your hospitalization there. But the problem is, if you live in rural America like I do, it's not so quick to just drive there. I live in a place where there's 3 canyons and you can't leave in the winter if there's a winter storm. You can't fly anybody out with a helicopter. You can only drive slowly out if there's somebody having a time sensitive emergency. So if you take hospitals out of rural America, it results in poorer health and a higher rate of death and really a higher expense. So you've talked about in your book a workable solutions, some solutions that you suggest. And I realize we'll run out of time before we run out of the entire development of that. But I would like to point people to the book and have you give kind of a synopsis of where would you point people as they feel the passion and they feel this drive and they want to change. What would you tell them to do?
Just briefly stated, the solution for our problem is better, simpler healthcare financed fairly for all. We have plenty of money in the system. We don't need more money. We need the money that is currently already there. And most of it's public money. Most of it's taxable money. Americans pay higher healthcare taxes than do the citizens of any other country. We need to not give it to the for-profit interests that are, quote unquote, our healthcare financing system, which is private for-profit health insurance. That business model needs to die. It needs to go away. Instead, there needs to be a publicly oriented financing system that very simply pays for healthcare. For the hospitals, it negotiates a budget. It basically says, how much does it cost to open the doors, pay the staff, feed the patients, buy the medications, et cetera? What does it cost to do that? What's your community health mission and how do we meet that financially? There's plenty of money to do that. It's not like we're going to have to, raise more taxes or anything. There's plenty of money to do that. So we go to each hospital in the state of Utah. We're proposing to convert the Public Employees Health Plan, which currently serves 200,000 Utahns who are public employees or their dependents, and instead basically say, you're going to take care of all Utahns, everybody. They have the lowest overhead of any payer for health services in the state of Utah, other than Medicare and Medicaid. Theirs is about 4% overhead. The typical private for-profit plan runs well over 20%, up to 30% with their rent-seeking behavior and the way they mismanage things. We'll turn it over to a nonprofit private trust fund, which is owned and operated by the people of Utah for the people of Utah. Instead of Public Employees Health Plan, we'll call it Utah Cares. We will negotiate budgets with every hospital and every other health facility, pay them directly. So if you need care there, you walk in, you don't have a bill to pay afterward. So people are no longer frightened by the possible financial embarrassment that a health problem might represent to them. Physicians need to be paid better. Nurses need to be paid better. We built that into our model. A substantial raise for doctors, and those fees will be negotiated with the physician community by the payer, by Utah Cares. It's that simple. Everybody's enrolled. Nobody's never, ever unenrolled. All physicians are on the list. You can go see anybody you want to go see. If you don't like your family doc, go see somebody else. It's totally in the patient's hands. And the doctors are told, just make sure that they get the care they need. If it's hypertension or diabetes or whatever, you find a way to treat them. You do the best you can. We'll support it. That's what the financing's here for. Make sure the patients get the care they need. We'll use our monopsony buying power. We're buying medications and medical devices for all Utahns. We'll go and use that monopsony buying power and get better deals from the pharmaceutical industry. Utah's got 3 or 4 million people. That's about the size of the VA. And the VA has monopsony buying power that gets their pharmaceuticals at 60% what the rest of us pay for the same pharmaceuticals. That's what we will do. Policy's not hard. It's the politics that are hard. Those corporations I'm attacking, they're the ones that have the $6 trillion a year, and they're going to fight it tooth and nail. They already have. That's the problem. It's the politics. And to that, I say to the people out there, stop electing the same people. Make sure you unelect people every time you have a chance, because they've already shown themselves to be more interested in the medical industrial complex than they are in taking care of patients. Unelect them. I don't care whether you usually vote Republican or Democrat. Forget about the party. If it's an incumbent, vote for somebody else. In Utah, we're going to put on the ballot this Utah Care system because I can't get it through the Utah legislature. And I want to go all around Idaho and all around the rest of the Intermountain states, show them my film, talk to them like this, and try to help them get organized like we're getting organized in Utah, like the people in Colorado are getting organized, and get it on the ballot and get people unelected so that we can actually make a change. That's what I tell people to do.
Man, I love your passion. It's awesome. Where can people go to find out more about your work, your books, your movie, and the Utah Cares Act that you're working on?
You can find a full copy of the Utah Cares Act online at utahcares.health. That's the Utah Cares, which is a political issue committee. That's our website. And on that website, in addition to the actual statute itself drafted, you'll find all of the economic studies, and there are 3 of them that support the economics of what I'm talking about, that we actually can afford to do this. You also will find a link to the movie Healing Us. It's on YouTube, so you hit the link and it takes you to YouTube and you can watch the 75-minute film. You can email directly through the website and let me know that you might be interested in having a community screening of the film. And if I can possibly get there, I will. I'll go. I just came back late last week from Colorado, a small little town called Paonia in the middle of Colorado mountains. And I mean, I'd had a screening with about a half a dozen people at it. I will come. I will help you understand this problem, show you the movie. We'll talk your way through it. It'll help coalesce more and more people, because I think most Americans know that the healthcare system sucks. They know it's wrong. They don't blame their doctors for it. They see the doctors are victimized by it too. They don't blame their nurses. They know something is wrong. They have a hard time articulating everything that I've learned to articulate. So I'll come and help you. And let's get this thing done. I want to start groups in Idaho, in Wyoming, in Montana, places where patients who have tertiary care needs often come. They originate from those states and they come to Salt Lake City. I used to see them when I was here in training. I want to help those states because we're all in this together. Let's get this thing done.
Thank you so much for sharing. I'll put your link for the website in the show notes. And again, I appreciate you taking the time to share both your observations and your passion about this, because I think it highlights something that maybe we don't talk about enough, the importance of being an advocate for systemic change that really benefits patients and makes it so that healthcare workers can still be healers and not just pawns in the machine. So thank you so much. I appreciate you doing that, and I hope you'll keep in touch.
Oh, I'd love to talk with you more.
Thanks for tuning into the Doctors Making a Difference podcast. And thank you for what you do to help your patients and your community. Your work truly helps so many people. We produce this content to help you have the tools you need to stay in medicine and to highlight the amazing work being done by physicians around the world. Please note that while I am a physician, and many of the guests on this program are also physicians or other professionals, the discussions on this podcast do not represent my employer or any professional organizations to which I belong. This podcast is for your information and entertainment only, and should not be taken as professional advice. You should seek appropriate professional advice pertaining to your own situation. Please check out more of our content on our website, doctorsmakingadifference.com. Also, please follow, like, or subscribe on your podcast player or YouTube channel, and give us a 5-star rating. It really helps to spread the message. Finally, if you'd like to be a guest on the podcast, or if you'd like to nominate someone else to be a guest, please visit the website or email admin@doctorsmakingadifference.com. See you next time.